And welcome to our research series. I'm Ada Hoy and I'm the UK Head of Research at the Royal College of Nursing, and today we'll be focusing on myth-busting monsters. So if you've missed any of our webinars from our research series so far, these are available on the Nursing Now channel, and we'll post links to those in the chats throughout today as well. And I'm absolutely delighted that our guidelines for our research proposal are also now live. So do have a look at the Nursing Now website for these, and we'll also be posting the link shortly. And this is for a chance to win our research prize as part of this series, which is a 3-day pass to attend our RCN International Nursing Research Conference, which will take place between the 15th and 17th of September this year. To be eligible to be in with a chance of winning a prize, you must be either a student or early career nurse or midwife, so within 5 years of graduating to be eligible to submit your research proposal as part of this. But for our session today, I'm absolutely delighted to be focusing on dispelling myths and misconceptions about research, quality improvement, and evaluation. So in research, we often talk about the importance of positionality. That's around being objective or unbiased in what we do and how we think and how we conduct research. But as a nurse or midwife, we have unique expertise and perspectives. And so I really wanted to challenge this and encourage you to think about being honest and transparent about your position, because your lived experiences and how they shape your viewpoints are your ideas and perspectives, and use these really to your strengths rather than seeing this as a weakness within research. When we think about positionality, I also often get asked whether I position myself either as a nurse or a researcher. And my ambition is that we no longer think about these as two distinct entities. So no longer thinking about whether we are either a nurse or a researcher, but thinking about being a nurse as being synonymous with being a researcher in our curiosity, our questions, and our ways of thinking, so that we can genuinely practice effectively using the most up-to-date knowledge, evidence, and research in what we do, and how we inform and engage with policies, practice, education, for example. So in our session today, we will focus on 3 core areas. So we'll focus on how you might get involved in research, whether this is through greater knowledge, awareness, how you might facilitate research, participate in research yourself, for example, or whether that's through research leadership. We'll also be learning from our speakers around international perspectives and navigating research careers across different systems and the lessons that they've learned throughout their personal careers. And we'll also be examining the relationships between research, quality improvement, and evaluation. So I'll be posting some links shortly for you to guide your way through research, and particularly the different types of research methods that you might use. So I was involved in leading the development and design of some research modules. So it's our Royal College of Nursing Introduction to Clinical Research programme. And these modules really guide you through the initial steps of how you might formulate and design research questions, how you might design a research study, and how you might be involved and engaged with research. So I'll post that link shortly. But in the meantime, I'll be introducing our first speaker. So unfortunately, Claire Whitehouse couldn't join us in person today with it being bank holiday and school holidays in the UK, but she has recorded a video to share with us. So Claire is a senior nurse and clinical director for research and development at the James Paget University Hospitals in the UK. She is also a professor of healthcare research and innovation at the University of Staffordshire. And she has a background in critical care nursing with over a decade of research leadership experience. Claire has led research teams across major NHS organisations, and her research focuses on workforce readiness for research. So Martine, if I could ask you to share the video, please.
Hello everybody, I'm Claire Whitehouse, Senior Nurse for Nursing, Midwifery and Allied Health Professions Research and Clinical Director for Research and Development at the James Paget University Hospital NHS Foundation Trust in Norfolk in England. I'm also Professor of Healthcare Research and Innovation with the University of Staffordshire. Now, I've been invited here today, and thank you very much, Ada, for the invite, to give you a little bit of background about myself, but also to think about those monsters, those myths, and to share some practical ways for anybody to get involved in research. So first and foremost, there's a QR code here that will take you to a Padlet that talks a little bit more about my career, because I was actually asked to do a career talk for some students a while ago. If you're interested in people's stories, feel free to have a look. There's all sorts of photos in there and explanations about how my pathway has grown. The top left picture there is myself as a student nurse at Coventry University many moons ago, which is where this all started. Once I qualified, I went straight into intensive care nursing, and that was really my clinical baby. That was the thing that I loved more than anything else. And that photo in the second one there, that was in Taunton in Somerset. And then I left Somerset and I moved to London, and I worked at UCL, University College London Hospitals, and at Imperial College over about 4 years. And this is where I really started to see research happening with the patients that I was caring for in intensive care. So people would come along and they'd ask for perhaps blood samples and things like this. And I would, like a 5-year-old child that I can be sometimes, I would say, why? What's this study? What's it trying to do? And that was really where I started to understand that research wasn't just about reading papers. It was about actually getting involved, and the patients that I was caring for were, generously participating all of this in this research activity that was happening. And whilst I was at Imperial, I worked really closely with Martin Stotts, who is a consultant anaesthetist and intensivist. And I said to him, I'm really interested in burnout in nursing staff in critical care. Because when we were at St Mary's, we were turning into one of London's 4 major trauma centres at the time, and I was thinking about how this might impact people. So there's 2 things happened. One, I found some funding from the Florence Nightingale Foundation, who funded a course with King's College London, so I could understand research methods in a different way. And then in parallel to that, I designed a study around burnout in critical care nursing staff. And so it was that real kind of identification of, this is how you can be part of research by delivering studies that other people design, or you can have some critical inquiry in your own mind and you can generate your own research ideas. And that's what started to happen with me. And then I left London and moved to, I live in Norwich, but I work in Great Yarmouth. And the photo here on the left is Dr. Willie Nutcutt. And we did lots of research around cannabinoid and cannabis therapy, particularly for pain for patients with cancer. And it was around that time when I thought, we're not visible enough as research teams. So in that role, I was a senior clinical research nurse. So I had responsibility for building research readiness in staff and in the organisation to build capacity and capability to do research and to grow that even more. And then after I'd been there a while, we had a huge funding cut, and we needed to think differently about how we were structured, what our strategy would be. So I went back to the Florence Nightingale Foundation, secured another scholarship, and I went off and about over a time period across the UK and Ireland, learning from, I think it was 43 different organisations across the UK and Ireland over about a 9-month time period. And created what is now known as the White House Report, which is the blue picture there. I then went off and had my first little baby, Eva. And then when I came back, there was a launch of National Institute for Health and Care Research 70 at 70 programme, which is now known as the SRL, the Senior Research Leaders Programme. This was the precursor to that. So we were given 15 hours a week, fully funded for 3 years to build capacity and capability for nursing and midwifery staff. Phenomenal. I added allied health professions onto mine because they didn't have anyone to sit with. So, a real privilege to be part of that. And one of the things that I did was set up a specific NMAP, nursing midwifery and AHP research and evaluation service. I appreciate that paper there that comes up says 2022. It was prior to that, but by the time we wrote it up, it was about 22. In 2020, COVID came along, and I think really that really brought research to the fore across media and everywhere else. And I think it really demonstrated that idea of research delivery, so delivering studies on behalf of others, making sure that patients had opportunities to take part in these studies, but also in the us as a nursing profession going, right, we can see what may need to happen here with modes of working and models of working and pathways and care pathways for patients. And when you think about it, nurses, midwives, and AHPs provide 80% of hands on care to patients. So, in my view, it's absolutely right and proper that we lead and generate our own evidence base. And then I started to kind of to link in a little bit more with academia and universities, and started writing grants with some of those organisations as well. And then through a part of that, I started a PhD. If you'd have ever told me I'd start a PhD when I first started my nurse training, I wouldn't have believed you, but I absolutely love it. It's research through and through. I'm really enjoying it. I've got some amazing supervisors. There's two of the three there in the photo, Mark and SJ. It's a big thanks to them for their support, and to Beck, who's over in the US, who's my third supervisor, because they support me continuously, and my study is currently live. And then in my actual job, we set up a embedded researcher model, which is a pilot that's happening at the moment with Linda Tinkler up in Newcastle University Hospital. And then another really big part of what I do is about supporting other people and mentoring and supporting people to write, as well as to go for grants and build capacity and capability. And this paper is actually one of the reasons why Ada has invited me today. So Naomi Hare, who you'll see on there, she's research matron at Guy's and Tommy's Hospital in London. And she said to me, is there a way that we can do something to help people understand, practically what advice can we give nurses, and, everyone actually, but, at every level, what can we do for nurses? So I want to say there's opportunities. There are opportunities everywhere. And the next couple of slides, we're just going to have a look at the myths and the monsters. We are then going to take some of the examples from the paper, directly from the paper, which we can share the link for afterwards as well. And then we'll circle back round to relook at those myths and those monsters. So here's some of the myths and the monsters. You have to be in a research role to be involved in research. It's impossible when you're running wards and departments. It's just too complicated. It's too hard. Nurses use evidence-based practice. We don't lead it. We don't lead the generation of it. This is what I hear and what I've heard my whole career over and over again. So let's look at this. So as I said, these have been taken directly from the paper. I've done that intentionally so that you have some familiarity to go and look at afterwards. There are some, I think Naomi and I would both agree that we've sort of had some updated thinking since we wrote this paper. So there's probably actually another paper that's due to reflect on this too. But I thought it'd be really useful to have some practical ideas. So this seemed the most sensible way to do that. So we've got 3 levels of engagement that we're going to talk about. So we've got awareness, facilitation, and leadership. And I'm going to show you how you can address each of those. So number 1, awareness. We have a nursing and midwifery code of practice. Within that code of practice, this is the minimum that we would be expected to be engaging and aware, research aware within our nursing professional roles. So you can join a library in your organisation. Most organisations do have a library. If you're in an organisation that doesn't, then there are lots of academic organisations that you can join their libraries for free, and it will give you all the access to a lot of that evidence base. You can sign up for email updates, so lots of research journals that are relevant to your practice or your specialty. Perhaps if you search for those, there is usually an update list and a feed that will come out to you, and you can usually select how often they come to you too. Research-related podcasts. In the last, I'd say 2 years, there are some fantastic research-related podcasts, particularly led by nursing researchers, actually. And so, again, if you Google those, you will be able to find them. They're really good. They're up to 10 minutes, so you listen to them in the car or if you're going for a walk or something, So it's really nice, really experienced, very practical examples of things that are happening out there in nursing research or research delivery. Journal clubs. Our allied health professional colleagues are very particularly good at these, so it might be worth having a chat with those. And the other thing you can do is shadow a clinical research nurse within your organisation too. So there are a few examples around awareness. So facilitation, anyone can facilitate research to happen. If you are here and you are running a ward or a department, and you think back to that monster or that myth that was around it, there's just too much. I don't know, how can I do this if I'm running a ward or a department? Let me tell you. So your organisation will have, at the time of writing this, lots of them had specific research strategies. Not all of them do now. Lots of them have morphed them into clinical strategies, and then there's components of research within the clinical strategy. And the idea being that it becomes more embedded in routine care rather than being something as seen as an extra. So have a look at your local organisation and see where research features. You could consider taking on a link role, either yourself or within your ward, within your department or service, and that could be a link role that's linked up with the research team locally. There's a training work package called Good Clinical Practice (GCP), which is offered for free by the National Institute for Health Research. There's a link on the screen here, but if you Google NIHR Learn, LEARN, NIHR Learn, it will show you that it's not just GCP that's available. There's a whole host of free, brilliant training, and you just register to join. It's free to register as well, just to be clear. You can display information about research studies that patients can participate in. So usually there will be some sort of promotional poster that comes with research studies that are happening. You can speak to your R&D research development departments about that and get some of those. You can put them up on your boards in waiting areas, clinic rooms, those sorts of things. If you see a patient come in who has, for example, Crohn's, and you think, oh, we've got I know that there's a research study that's happening that's something to do with Crohn's. I don't know the detail of it, but what you can do is refer your patient to the research team. This is no different to having a patient who maybe has a wound that's not healing properly and so needs some expert support to come in and look at that. And you would naturally refer that patient to the wound care service or the specialist nurses. This is the same thing, it's just thinking research. Hub and spoke placements is something that not everywhere offers, but lots do. And even if they don't offer it, then why not set some up? I think that's a really good idea where they can see what's happening with research. So I'm just giving you a couple of examples here with the red highlights, but there's lots of different ones that you can take a look at. And then level 3 is around the leadership. So what's really great here is that we've got a lot of local, national, regional as well, actually, research priorities. James Lind Alliance is listed on here, but actually in the last few years, we have the Chief Nursing Office research strategy. We have our very own RCN research strategy. A big thanks to Ada and colleagues who developed that, and that was launched last year. So again, brilliant to have our own Royal College that's celebrating that. And we also have the NIHR Nursing and Midwifery Office. There are so many organisations that are leading this now that we can draw from as individuals, as services, as a professional group. Why not is what I would say. When you're thinking about that leadership, it's determining your own areas of interest too. So understanding what evidence is already available on those, and then identifying some of the gaps. And there are people out there who can help you with that. There are some research internships. Now, this might offer you a day a week over a 3-month or a 6-month or a 9-month period, which offers some funding. It offers a backfill. It offers you ring-fence time, and it provides you with usually mentorship and then support to grow an idea or to just learn more about research activity and how that can happen within your organisation. Lots and lots and lots of community of practice opportunities out there now that, there may be something that exists already within your area of interest. There may not. And if there's not, why not lead it? Why not set one up? Now, this circle's slightly, the other way around. And this is because all of these are about seeking information. But we thought it was really important to include this because there is so much information that's already there. We wanted to let you know where you could go. So your local research and development departments, absolutely. your specialist nurse professional organisations, or organisations that are specific to your specialty. The RCN has a research committee now as well. The NIHR, on here it says Clinical Research Network. In the last year, it's transformed into the RDN, the Research Delivery Network. So just to be aware of that, if you are Googling the NIHR, it will say RDN rather than the Clinical Research Network. You may want to start thinking about publishing your work, because as nurses, we have lots of information, lots of data, lots of projects, amazing work happening all the time. We're not as good as publishing it as we could be. Now, maybe that's because we need to find more groups that know how to write and need that support. Where can you go for that if that doesn't exist in your organisations? Contact a local university or a university that you might see on, if you're particularly au fait on social media and looking around, then actually LinkedIn's quite good for this sort of thing. If you see things that come up and you think, well, that university seems to be doing a lot, they don't have to be local to you. Contact them. Just contact them and have a conversation. That's what I've done, and that's how I've made a lot of links with people, and it's always been really great. Usually you end up writing with them, which is lovely. And then supporting colleagues and teams to be increasingly research active is really important too, and it's all about that positive research culture. There are some other practical things that are happening more and more now. So things like job planning, having job planning discussions, influencing some of the strategies that are happening around you, and also including specific elements of research within everybody's appraisals. This is something that's really important because people do take note of those. So let's go back to the myths and the monsters. So number one, you have to be in a research role to be involved in research. You do not have to be in a research dedicated role to be involved in research. It is possible when you're running wards and departments. It might look slightly different, but it is possible. It's too complicated, it's too hard. No, it is possible. There is training and there is support out there. You just need to know where to look, or you need people like us to tell you the different places that you can go to search that out. And nurses use evidence-based practice, but we don't lead it. Nurses use evidence-based practice. We can lead it and we can facilitate it. And in my view, we absolutely should be responsible for it, for our own profession. Thank you very much. I hope you have a wonderful rest of the session.
So hopefully that video has given you a real insight into how you might engage with research in different ways, particularly thinking about, whether that's using your expertise, for example, as part of an expert advisory panel to really shape what it means to be involved with research, whether it's to shape strategy, whether it's involved in shaping research studies directly, or whether that's leading research as well. So we'll move on to our next speaker now, who is Dr. Clarissa. Dr. Clarissa is a senior lecturer is a lecturer in nursing at the University of Edinburgh and the postgraduate research director for nursing studies. She's also an honorary advanced research fellow at NHS Lothian, and her research expertise includes qualitative and realist research methods, as well as intensive care, stroke, acquired brain injury and rehabilitation nursing. So do please post any questions that you have to our speakers in the chats as we continue, and I'll hand over to Clarissa.
So good afternoon, everyone. It's really a delight to be invited to speak to this session because I was part of their Nursing Now Challenge. So it feels really nice to be back again. And I was asked to share my experience, my international experience, and how I get into this research career as a nurse. And also, I will also share the lessons learned from my experience in my research career, and also some things that I wish I'd known sooner doing this career as a researcher. So I don't have a lot of slides, but probably sharing pictures would be more interesting. So let me advance to the next slide. So I'm originally from Indonesia. So if you recognize the flags there with red and white. So I was trained as a nurse in Indonesia. I did my bachelor degree there. It feels just like yesterday, but actually it's already ages ago. So this is the picture of my graduation. So I started my undergrad in 2002, graduated in 2007. I firstly secured my job in a clinic, but only worked there for 3 months. And then I needed to move to another city. And in the new city, I work firstly on a general ward for about a year. And then I was transferred to the ICU. And that becomes kind of my passion really in critical care. And yeah, I will share later because I pick also a topic related to critical care for my PhD. So yeah, I work fully clinically before I kind of did my higher education. So this is a picture from 2014. So it's already 12 years ago. So in 2014, I got a scholarship to pursue an MSc in Advancing Nursing Practice at Edinburgh University. And at that time, well, Edinburgh University is very research intensive. But to be honest, when I was doing my career fully clinical, I wasn't really thinking much about research, probably just thinking about delivering care for patients, but not really thinking much about research. But studying at Edinburgh really forced me and also opening my eyes about the importance of research and how nursing as a profession, we are very evidence-based. For example, probably years ago in critical care in the past, that if we wanted to visit patients or relatives, we need to wear a specific gown, and then we need to take off our outside shoes and then use kind of the shoes provided by them, and then wear mask and everything. So, but evidence shows that it's actually the most important thing is hand hygiene, hand washing. So we stopped doing that now in the intensive care. So that's kind of a short example how evidence kind of influence practice. And this next picture, these are my lovely friends from my PhD. So after finishing my master's, I went back home, and then my nurse director, I remember, she asked me to share my experiences studying abroad, and that's kind of the easy part. And then she started asking me, like, could you update our SOPs and then update with the current evidence? And I was like, okay. I was a bit apprehensive because I understand research at that time because I wrote a dissertation and then learning a lot about research. But at the time, I felt like I know research, but still in between. So I don't really fully know research because I haven't done research myself. So that's kind of basing my decision to pursue a PhD. So I applied for a PhD program still at Edinburgh University because I know that I was very well supported by the university, by the school, but by my dissertation supervisor, which also became my PhD supervisor. So I went back to Edinburgh to do my PhD. And this is me after finishing finally in 2021. It was a very long and arduous journey, but after I finished, I did a short work postdoctoral as a postdoctoral research assistant, and in a research project called YARNS, Young Adult Rehabilitation Needs and Experiences After Stroke. And actually having that experience working in YARNS, it kind of started to build and develop my research career because I applied for postdoctoral fellowship mentored by Colin Chandler, the PI, and also Aisha Holloway as also the PI of the YARNS project. And then it wasn't successful. So that's one thing that probably lessons learned in research career, we need to really know that rejections are very, very normal. It's something that I wish I've known sooner, because of course, when you first kind of submitting, you put a lot of effort and then you submit a grant application and then you didn't get it, you feel like, oh my God, I wasn't really capable to do this. But actually, rejections in academia, they are very, very normal. And just wanted to highlight, they don't really reflect your self-worth. It's just because the nature of the competition in academia. So, so this is kind of my last slide, really, just wanting to share the lovely pictures of my research team. So yarns have been kind of developed arms and legs into different projects. So the current one, we call it Yarns Transitions, and we branch out still around young adults rehab, but branching out to acquired brain injury. So we also included young adults after traumatic brain injury, not only stroke. So these are the lovely team, which I also wanted to highlight in building a research career. We need to realize that research is a team effort, although even, let's say, if you're doing your PhD, you're doing it yourself, but your supervisors are there, your family members, they are also part of your team, your friends. So it's never your individual work, and being surrounded, having a very, very supportive team in your research, that is very, very crucial for your success. So I'm going to stop sharing now. And I don't know how much time that I will have, but I'm happy to accept any questions from all of you later on. Yeah. But Ada is here, so I'm going to hand over back to you, Ada.
Thank you so much, Clarissa, for your really inspiring talk and for sharing your, amazing experiences throughout your research journey so far as well. I'm really curious and excited to know what you've got in store next. We will, if anybody does have any questions, please do type them into the chats, and we'll go to questions and discussions at the end of the webinar today. So for now, I'll hand over to our next speaker. So our next speaker is Dr. Maria Holden. And Maria is a children's nurse. She is also an assistant professor and global engagement lead at the School of Health Sciences, University of Nottingham in the UK. Her PhD explored factors associated with paediatric burns injuries in rural and peri-urban Malawi, drawing on a unique interdisciplinary collaboration between engineering and health sciences. She has contributed to international burns care initiatives, and since 2023 has served as the quality improvement lead for Interburns. So Maria, over to you.
Thank you so much, Ada. Can I just check you can see my screen? Because for some reason my screen's gone a bit funny, but it says that it's sharing. So great, I've got a thumbs up. Brilliant. So good morning, good afternoon, everyone. It's a real pleasure to come and speak to you. And it's really helpful, I think, going after Claire and Clarissa, because they've already highlighted so many myths that will I can blend into some of what I'd like to talk about today. So I'm actually not going to focus on my PhD work today. I'm going to focus on a programme of work that I've been developing alongside other nurses from France, Malawi and Tanzania, with Interburns. And Interburns is an international network that works with local healthcare professionals to improve burns care prevention and training, particularly within low resource countries, although a lot of what we've developed as part of this scheme is perfectly transferable to a number of settings. It just needs to be a bit flexible. So during this session, what I'd like to do is just sort of outline some of the lessons learned around the development of this scheme and what it is and how it's grown, and how it's helped to empower nurses to drive change in settings where resources are limited, but there's a real commitment to improve care. So hopefully it's going to let me move the screen. Okay, this is a bit of a worry. It's not okay. Here we go. Apologies for that. So I'm not going to dwell too much on this slide because I'm actually really mindful that Claire has already addressed a number of these myths. But what I really want to just reiterate is that key thing that actually nurses are so uniquely placed with that clear set of skills and values to understand the context in which we're applying the research. So throughout this session, I really want to reiterate the importance of that research and nursing practice aren't separate. And in fact, nurses are so integral for the implementation of any research into practice because they understand the context and they better understand what the situation is. And I do think that these kind of real common assumptions and misconceptions that research is this big academic thing that nurses have to step away from practice to do. And actually that creates a huge gap in relation to the implementation of that evidence. And actually, the most meaningful practice actually happens looking at those small incremental changes in relation to what we can see in our clinical practice. And I think Ada and a number of the speakers before have talked about being curious. And I think a lot of this is about that curiosity and why maybe implementing certain elements of research and evidence-based practice are challenging and unpicking that. And much of what we do every day around observations, evaluating and decision making are the key behaviours at the heart of quality improvement. And it's that thing that kind of, it is what it is. It's that implementation of research into practice. So why the QI scheme was needed. So aside of what we've already talked about in relation to the myths, we know that particularly in, across a number of different specialities, that there's a real lack of coherence between those who are maybe doing the research and those who are actually implementing it. And certainly in some of the countries that we've worked in, there is that lack of ability to, not lack of ability, but a lack of inclusion of frontline staff members within that wider research. And that's really detrimental because it weakens what the implementation of that work. But it also then frequently this research then struggles to address practical barriers or adapt the interventions for local realities. So the Interburns scheme was created as in response to that, as an explicit aim of supporting nurses to translate evidence into action within their own clinical environments. So if I talk about the origins of the scheme and where it started and where it is now. So the scheme itself was developed as part of Interburns, which is the INGO, and what was the Centre for Global Burn Injury Policy and Research. Apologies, I look over to the screen. It's because my presentation is on a different screen, so apologies, I'm looking across. So it was originally piloted in Malawi and Ethiopia, and the purpose of this was that Interburns runs programs called Advanced Burns Care Nursing, Advanced Burns Care Rehab, and Advanced Burns Care Surgery. And the purpose of this research is to help support nurses and practitioners working in areas where burns are prevalent and there's a need to support practice. However, one of the key needs of that is that it's not just about providing that initial training, but there was a need to provide ongoing support to be able to implement any of that training into practice. And actually, a lot of around implementation is not around the capability or the competence of nurses, but it's around trying to understand the structure and the process that prohibits the ability to implement good nursing practice. So that was really the driving force of developing this scheme as a way to complement existing training programs. So we piloted this in Malawi and Ethiopia, and over the next couple of slides, I'm going to explain how we developed the program and the importance of sort of taking context into account as both part of research, but also part of implementing any kind of program. And the real purpose of this was also to think about applying sort of that real clear, I'm trying to think, I've lost my train of thought now. It'll come back to me. Yeah, okay. So what the scheme includes. So the idea of this scheme is that there are kind of 4 pillars. So the first, in terms of teaching and learning activities, the first is that participants will have attended an advanced burns care nursing programme. And then following that, we support participants within the QI scheme for about 9 months after that initial ABC nursing programme, although sometimes it can be a little bit longer. And we do hope that the participants that take part in that scheme continue to maintain a community of practice through our WhatsApp and sort of informal collaboration. We then have sort of 3 weekly meetings online, and this can either be participant or facilitator led. But the idea is that this programme builds confidence and capability to lead improvement. And rather than focusing on theory alone, it combines those foundational concepts of implementation science, but with hands-on tools that can be applied immediately into clinical practice to develop a quality improvement project and sort of understand how measures become framed as a routine part of practice rather than an academic exercise or something that is seen as separate. But this also helps participants in the wider practice see how simple data collection and small improvements can make a real case for change. A key component of this programme, and I think for any programme that is looking to support nurses undertake research, is mentorship. So when we were developing this programme, we really looked for nurses who, one, understood the context of burns care within the context in which the programmes were being run, but also had an understanding of quality improvement. So they, between our online facilitated meetings, can then support on a one-to-one basis. And then at the end of the programme, we like to share the group's projects and their development, and they can we do that through an online forum, so they can disseminate their work more widely and sort of inspire others to get involved. So I just wanted to share something, because although it's quite easy to talk about this scheme, there's a number of things that go on behind the scene to develop a programme like this to ensure that it is suitable for context. So we spent a long time trying to actually understand what some of the key barriers and facilitators are around doing research, and I'm going to talk about some of those later. But that then helped develop our curriculum and teaching and learning activities around supporting nurses to do quality improvement and small-scale research within their units. And within that, it meant speaking to nurses across, for this particular pilot, the initial pilot, across East Africa, and also practitioners who look specifically at patient safety, leadership and measurement. And the idea is that we can bring that faculty in, support the expertise, but also allow nurses who are part of this scheme to actually access teaching faculty that can lead in this area. We also have to think about logistic locations and stakeholder engagement. And I don't think it's any hidden thing that we have to, is that stakeholder engagement, whatever you do at whatever level, is vitally important. But certainly for interburns and for this programme, there was a real need to make sure that whatever we do in relation to this programme aligned clearly with local priorities. So just having to think about how that scheme has since developed. So we're actually now about to embark on the fourth iteration of this scheme. One of the key sort of ways and means that we've aimed to sustain this is actually through each iteration, the people who were participants in the first programme are now the mentors in subsequent programmes and or have taken on the lead of those programmes, which is really helpful and wonderful, because it means that nurses are supported more directly, but also those people who've already been through this programme understand the difficulties and the challenges and help identify how to manage research and quality improvement within the constraints of that maybe particular environment or organisation. So we have our mentors. We also have developed, as part of the supporting materials and resources, a practical guide to quality improvement and burns care. And this is an online resource that we use to complement our training programme, but it's also open to anybody. And essentially this resource uses the pilot projects in particular as a worked example of doing quality improvement within a resource limited setting, with some videos, some recordings and some text. And this has been really helpful in terms of providing contextually relevant resources. Like I've mentioned before, we've I think a key thing here, and I think this was quite clear in Claire's presentation as well, is about increasing that voice of nursing within this in terms of publishing and disseminating the work that we're doing. So last year, when we completed the third iteration of the programme, we then held an online evaluation and sort of webinar for the nurses who undertook that programme to share their quality improvement projects. And this allowed them to disseminate their work more than just locally, but we're also aiming to support nurses within these programs present at national, international conferences, and also through peer-reviewed publication as a ways and means to increase the nursing voice, specifically at subject-specific conferences. And then we're also looking to develop our curriculum a little bit further to make sure that it's flexible and responsive to wider geographical areas. So I don't believe that it's ever possible that you can perfectly lift something up and put it somewhere else. But the hope is to adapt this now for Sierra Leone and Ghana, and then also for wider programs that Interburns offer, such as rehab with our physiotherapists and occupational therapists. So I guess I've talked about the programme, but what I really want to show you, and I think is a real key myth about this, we need extra resources, we need to develop things. Well, one of the key benefits of this programme, or maybe not benefits, but what this programme highlights is that research does not need huge amounts of funding. And actually, when you're working in very resource constrained context, asset-based development and considering how to reorganize processes and standardize things can actually make quite significant improvement to staff experience, patient experience, and patient safety. And on the screen are a couple of examples of quality improvement projects that our participants have undertaken throughout the scheme. And a lot of these, like, for example, just standardizing processes around pain control before dressing changes, all of the things that are presented are essentially quite were low cost and feasible, and just resulted in clearer processes, better communication, and improved patient experience by addressing practical barriers that maybe had previously gone unrecognised. And these all reiterated the importance of good measurement and highlighting measurement as part of something that we do, and research that we do as everyday practice. Now, all of these projects, none of them, went start to finish and had made huge improvements in one quality improvement cycle. And I think it's important to note that for each of these projects, it takes a number of what we call plan, do, study, act cycles to actually achieve maybe the improvement that you're looking for, and fine tuning and tweaking actually what is it that you're implementing in practice that is making the difference, and actually where do you abandon something, or where do you adopt something. So throughout the programme, we've also spent some time considering the challenges that nurses face in relation to doing research and implementing evidence-based practice, particularly in resource-poor contexts, although I imagine that many of you who are looking at this slide maybe don't work in a resource-poor context, but can recognise that these are also issues globally that nurses face. But they're really important when we're thinking about research directly, to understand the context in which that we're trying to deliver quality improvement, because recognizing these challenges helps us ensure that our improvements projects remain realistic and focus on what's changeable and sensitive to the realities of every day, and working within our sphere of influence and competence. And I think it's important that despite a number of these constraints, and considering the projects that I'd highlighted earlier, that a number of projects were able to succeed, and there were real common enabling factors that began to emerge, and I also want to share those with you. So the key things that enabled change were things like supportive mentors, senior staff, motivated individuals, and, like I've mentioned before, that importance of regular small measurement to be able to demonstrate those small incremental changes, and actually present that back to the staff within the unit. But what I think the key thing is here is when we've actually asked questions around what enabled change, it wasn't money, it wasn't resource, it was about supportive mentors, supportive senior staff to provide encouragement and the space and the permission to actually undertake this as part of their role, and give the value and the recognition to it. Because the reality is, when we're trying to look at this implementation, it's not necessarily always about more resource. In fact, often that sometimes misses the point, because it's actually a process that isn't adequate or doesn't suit what needs to be. And then kind of going forward, just thinking about the lessons learned and future planning, there's a lot we've learned from the development of this programme. It's not been straightforward. Not everything that we've done in itself has worked well, and we've had to modify and change as we've gone through. So breaking these down into our quality improvement projects, I think what we recognise, and I think an important message for today when we're thinking about myth busting is, did my computer just stop then? Because it just flashed. So hopefully I'm still there. Is thinking about that small tests are powerful, and actually working within our sphere of influence and thinking about what is it that we can do as nurses, as part of our role, as part of our key value, to be able to make better changes, that make change that's more effective, and support our patients. That measurement brings credibility. So where there is resistance to change, or maybe resistance to a new process, thinking about how we can use measurement to actually think about, instead of this being perceived as extra work, research being extra, it being recognised as better work, because it's improving both patient experience but also staff confidence and time in relation to each particular project. Within the scheme itself, we've learned a lot in terms of the delivery. So we know that having a good structure and a regular time to meet and using certain formats work really well. So WhatsApp in particular is really helpful to kind of maintain that community and links with each other as we're going through the frustrations of both doing research as well as celebrating those small wins. But we also need that flexibility. So when we're designing the curriculum, we're designing the sessions that we're delivering, it really needs to be flexible and reflective around the conditions and the circumstances that the nurses within each scheme are facing. We found that public webinars to aid dissemination and providing that ongoing support for participants to present and publish their work, because often much of the feedback we get, and we can see it, is that nurses aren't always necessarily represented as well at subject-specific conferences, because it's much more challenging for them to maybe get funding or get support to present at those than maybe their medical counterparts. And lastly, thinking about our long-term follow-up. So we're thinking, we're very lucky that a number of our participants within previous schemes have joined us now as mentors, so we can see where they're developing, but it would be nice to see a little bit more about where our participants are maybe 4 or 5 years on beyond from the programme. Continue to develop and the sustainability of the programme through mentors and the development of programme leads, and then thinking about how we can adapt our scheme for other professions and locations. And yeah, I just really wanted to say thank you so much for giving me the time to present this today. And I really want to give a special thank you to all of our mentors and participants who've kindly shared their work to allow me to present this as part of today. And I think the kind of key myth here is the programme has shown what's possible for nurses when they feel visible and valued to support small-scale research within their context. So thank you.
Thank you so much, Maria, and to all of our speakers today for offering those, really, really insightful thoughts about, personal experiences and the practicalities of how to embed research in everyday nursing and midwifery practice. I'm just looking through a few questions here, and we've got one that is about speaking about approach to change. So a question to the panel: what is your experience and view in the use of AI in the research process? I'm deliberately leaving the question broad.
So I'm happy to answer. Yeah, so AI is always a hot topic now in academia. I would say use it as a tool rather than as a relying on that for critical thinking. So, for example, our university subscribed to Confidence for screening the articles. So that's definitely with AI. So that's kind of part of our research process, but we use it as a tool. So use it to delegate tasks that are quite menial, but don't replace it for any analytic work, because you are the brain power. So nothing can replace our critical thinking.
I think I would totally echo what you said, Clarissa. I think it's really helpful in some ways as to act as a additional resource, but it doesn't understand the context or same level of critical thinking. And I think again, it's about being curious about what it's spouting back, because some of it is not as reliable as others.
Yeah, I absolutely agree. And I think, for me, there's something about that lived experience and that personal expertise that you gain from doing the actual everyday things that gives so many different, different insights, but also additional insights that nurses and midwives have that you wouldn't get from an AI bot, as it were. So I think all of those things just add that, real richness to what we do, and goes back to what I said at the beginning around, the when we usually, often when we think about research, we talk about the importance of objectivity, when actually I think there's a real richness and a strength to recognizing, acknowledging, and being open and upfront about, what we do offer that is different. And that's not to say that bias is, is either a positive or a negative, but actually owning up to what is your positionality within this space, what actually really influences your perspectives on things, and how does that experience and expertise really lend you to, you know, to doing what you're doing and thinking the way that you do? I can't see any more questions, but if there are any, please do type them into the chats. I know there was a very specific question about fellowships and a specific fellowship in particular, but if you've got any broader advice, perhaps either Clarissa or Maria, on, you know, how people might think about or begin applying for fellowships, that might be helpful in a broader sense.
Yes, so I shared the link to the Burdett Fellowships for undertaking an MSCR program at our university. I believe the Burdett also funded different universities, so have a look. But I think Claire mentioned in her presentation that reaching out to people through LinkedIn, I think reach out to mentors as well. Maria, I absolutely agree the importance of mentorship. So reach out to people that you can brainstorm your ideas and around your research, because to get the accepted, not necessarily about the scholarship, but to get accepted in the research degree program, you would need to show appreciation of research in your proposal. So it doesn't mean that you should know everything about research, because you're going to study more about research, but your proposal needs to reflect that you understand about research. So again, talk to mentors, supervisors from your previous degree, for example, and yeah, reach out and talk to them, ask for advice.
Yeah, thank you, Clarissa. And I think that links to the other question that's just come through around recommending organisations that provide research mentorship, and particularly for nurses in Africa, but, you know, other places and countries as well.
Yeah, I think that's what it's a bit of a tricky one in some ways, because I think it depends like where you are and which country you're in, depends on which organisations are more present than others to support, particularly around research. But I'd also echo again what Claire had said in her recording around reaching out to certain universities within the region that may have an idea around alumni or scholarships that other people have followed, because I certainly think there are pockets of say funding and support, but it's a bit more region area specific. So it might be helpful again, like just to reach out to regional universities within that area to identify if there is any particular funding in relation to that, and or specific to the area of speciality that you're working in. So again, there's particular charitable organisations that will support. So for example, Interburn supports specifically burns, but there'll be other organisations again who support in relation to particular conditions as well. It's quite a big question, but I've got more questions than I have an answer for that one.
Can I add
but always
a
happy to
little
support
thing?
if you want to drop. Yeah.
Yeah, so just wanted to highlight there's also informal mentorship, which I found quite useful. So for example, before I submitted my application for my MSc, I just saw on the website there's a nurse from Indonesia. And of course, nursing is a small world. So what I did, I was just searching her name. And then I contacted her, I emailed her, and then we had a chat. So I suppose that kind of that's also an informal mentorship, that you could ask advice, how to get accepted, what's your experience there, which very, very important, especially if you are applying from abroad and you don't know the city, you don't know the university. So of course, individual experience will be different, but if they're happy enough with the support, so I suppose it's a good sign. So yeah, so make sure that you use your network to reach out to kind of mentors. Informal mentors would be also count as kind of support, I suppose.
Brilliant. Thank you so much. On that note, we are running really close to time. So thank you so much to Claire, Clarissa, Maria and Martine, who's been helping us in the background with the technology today. We've been absolutely delighted to have you all joining us today. And please do join us for our next webinar in our research series, which will be on the 24th of April between 2 and 3:30. British Summertime, and that will be our webinar on riding the research roller coaster. We'll be talking about ethics, researching sensitive topics, and how to look after our own personal well-being as nurse researchers. So I very much look forward to seeing you then. Do take care, and we'll look forward to seeing you very soon. Thank you all again. Bye-bye for now.
Thank you so much, everyone. Bye. Have a nice afternoon.